So welcome everybody to Integrated Care Training Part 2. I'm glad that you're able to view this video, even if you obviously have not been able to come to a group training, and hopefully you can discuss it with your colleagues that have also been part of this training. So we're just going to go through a couple of examples of individuals that you all might be seeing at Community Health Link, whatever type of job you may have. This gentleman is somebody that you could see in outpatient adult services, in our detox unit, in our primary care, lots of places. I'm 36 years old. I get really bad migraines. I have a lot of pain, so some days it's hard for me to move. I have a seizure disorder, high blood pressure, and fibromyalgia. I get really bad nightmares, and I'm very anxious. I want medication for this. I've been on psych meds in the past and they just don't help. I gained weight and then I feel even worse. Plus the last time I stopped taking them, the medication, I ended up back in a psychiatric hospital. The only thing that helps is pain meds. My doctors just treat me like I'm drug seeking, so I haven't seen a doctor in a long time. I can't trust that they will give me what I want, so why bother? I'm in the emergency room at least once a month for help. So obviously this gentleman has a lot of issues dealing with mental health issues, substance abuse issues, physical health issues, not to mention probably lots of psychosocial stressors in addition to that. If you work in our children's services, on Mir, Burncoat, you might see someone like this. Nina is a 16-year-old girl referred by primary care for issues relating to depression. She has been defiant towards her parents, failing at school, and was caught smoking pot. Nina was diagnosed with type 2 diabetes 1 year ago and is now on insulin, but often refuses to follow the diet prescribed by her doctor. Her primary care thinks that she is suicidal because she is not following her diabetes plan and would like her admitted to a psychiatric hospital. So, another case of, what comes first, the chicken or the egg? She's got significant psychiatric problems. She's got serious medical problems. Throw some substance abuse in there, probably a lot of family issues, and really a challenging situation to sort out. And if you work in geriatrics or lots of our outpatient services, we see elders. You might see someone like Eleanor. Eleanor is 78 years young. And when lucid, has a bubbly personality despite her health status. Family members have revealed her history as a severe manic depressive throughout her childhood and years, resulting in numerous admissions. At this point, she has early to mid-stage dementia, worsening renal insufficiency, obesity, and a fear of water, bathing basically. These health and behavioral factors have led to complications with the patient sneaking food and drinks, leading to increased edema, combative behaviors when discussing these instances. A lack of recall about her dietary restrictions and not allowing staff to bathe her has led to increased skin fold infections. So this is a very challenging person, somebody that our geriatric service might be seeing for sure. So our goals for today are to review why integration of wellness is important for our work, to discuss common wellness issues that you may encounter in your work. If by chance you're viewing this with others from your work site, you can certainly take the opportunity to talk about particular issues that are coming up for you. We'd like to provide an overview of ways to engage people in discussions about wellness using two tools, specifically motivational interviewing and solution-focused therapy. We will discuss ways to add wellness-oriented change goals to treatment plans. And at the end, although you're viewing this perhaps as an individual, we would like you to think about developing some program-specific plans to move integration forward in the area in which you work. So just to keep that in mind. So let's review why integrated care is important. So as many of you probably already know, individuals with serious and persistent mental illness have been dying approximately 25 years earlier than the general population. This was a study that was done back in the early 2000s, looking across the country There has been some progress since then, but even more recent data indicates that it's probably at least 15 years in comparison to the general population. Substance use disorders and makes it much worse. The average age of death can be as young as 45 years old, and we've certainly seen this in our work at Community Health and when we look at the age of death of our clients, especially in our outpatient programs. And while suicide accounts for a certain percentage of deaths among those with serious mental illness, at least 60% of deaths, and maybe a higher percentage than that, are connected to modifiable health behaviors and the choices that people make with regard to lifestyle. Our data at Community Health Link actually has shown that we have a much smaller percentage of people that die by suicide and a much higher percentage of people that die due to preventable medical causes. So, compared to the early 1900s, if we look now, 100 years later, people used to be dying of infectious diseases. So people would die of pneumonia, tuberculosis, gastrointestinal infections, and things like heart disease, cancer, dementia, things like that were a much, much smaller percentage of the reasons that people died back at that time. Now, people are living with and dying from chronic health conditions, so heart disease, and then all the cardiovascular diseases that go with that, cancer. Certainly at Community Health, and we have a lot of individuals with serious respiratory disorders, chronic obstructive pulmonary disease. We still have folks that are dealing with infection, certainly, but infection more on a chronic basis, so hepatitis C, HIV, that are manageable, but still tremendous health challenges for the folks that we work with. Complications of diabetes are a big problem. We're seeing it in younger and younger ages. It contributes to dementia and certainly contributes to depression and ongoing morbidity for lots of the individuals that we work with. So, what constitutes good health? How much of health can we even impact at Community Health Link in the work that we do? So, this is an interesting slide that was reported by, the information here is reported by the World Health Organization. So, if you look at, the entire if you look at healthcare and health in general as a 100% circle, about half of that circle is actually determined by lifestyle. So smoking, obesity, stress, nutrition, managing blood pressure, alcohol and other drug use. Maybe 20% is human biology, about 20% would be environment, and only about 10% is really, dramatically impacted by the actual provision of health care. So some of us would say, well, why are we bothering to provide health care? I think the point of this slide is just that we are able to actually impact in urgent situations, in getting treatments started for people, but that the vast majority of the time that people spend in their lives is obviously in their communities, in their homes, the way they choose to live their lives, and how they go about taking care of themselves is a big part of ultimate health. So people with serious mental illness are dying of preventable causes. And this really does start in youth. We're seeing lots of folks at younger ages, obviously in our child services, but even in the adult services, in our early psychosis clinic, in our substance abuse services. Young folks often feel pretty invincible, so they don't worry about these things so much, but we certainly see the ravages of these health behaviors over time. So obviously smoking, alcohol consumption, poor nutrition leading to obesity. We can have folks that are hugely obese, but their nutritional status is actually terrible. They can sort of be both malnourished and obese at the same time. Lack of physical activity, especially for people that may live in neighborhoods where they don't feel so safe in terms of getting out and walking, or don't have easy access to physical activity. Unsafe sexual behavior can be a factor in terms of unprotected sex, risk of STDs. IV drug use is a big concern. And simply living in group settings or homeless shelters can also increase your risk of developing adverse health conditions. The population that we deal with is particularly vulnerable. People that are homeless, those that have been victimized or victims of trauma. A huge percentage of the folks that we deal with of all ages are survivors of trauma, either childhood trauma, domestic violence, or just adult trauma in the community that's the result of living with mental illness and addiction. Poverty is certainly a huge factor among our populations that we work with. We've had a large number of people that have been incarcerated or certainly have had trouble with the legal system on many occasions. And social isolation can also really impact health status and your ability to participate more fully in health promoting activities. So, what about the lives of the patients that we work with? What do we know about trauma and how that affects, health over time? I would encourage you to look up the ACEs study. This was done back in the 90s with Kaiser Permanente out in California. So this was a large population of individuals that are employed. They have Kaiser Permanente insurance, so this is actually not as at risk a population as the population that we deal with. But even within that population, the higher the number of adverse childhood experiences, the greater the amount of social, emotional, and cognitive impairment, adoption of higher risk health behaviors, development of disease, disability, and social problems, leading specifically to early illness and even early death. And there's really a one-to-one correlation between these things. The adverse childhood experiences that they studied were the death of a family member, mental illness of a family member, active substance use, observing violence, certainly being a victim of violence. There's a number of questions. It's very easy if you want to look up the study, if you just Google ACEs, the ACEs study. You can pull it up and see for yourself. One of our clinicians at Community Health Link, working in juvenile justice, actually decided to give the ACEs survey to all the youth that she was dealing with, and found that the vast majority of individuals scored a 5 or more on the ACEs study. So it's definitely something that if you look at the early experiences of our patients of any age, you'll find pretty high scores. So what are the most common lifestyle and wellness issues that you encounter in the work that you do with your individuals? So I'm assuming some of you watching this video may be working the night shift. Maybe you've got folks that are waking up in the middle of the night and eating. Maybe they're getting up in the middle of the night to take a smoke. Maybe there are other issues that are coming up for them. So, no matter what time of day you're working or what your interactions are like with people, I would just encourage you to sort of think about, what aspect of this you might be able to impact. Getting reasonable sleep is huge in terms of weight management, blood pressure, mental health, staying sober. Again, whatever aspect of care you might be providing, kind of think about it from the lens of, what health behavior might you be able to help your clients with. So there's lots of wellness issues that people have. Accessing health insurance can be a big one. For some individuals, it's not as big a problem in Massachusetts as it is in a lot of other states, although I think at Community HealthLink, we end up seeing people who've lost their insurance because they don't fill out the correct forms, they don't have a stable address, they're a new immigrant, they may have language barriers, they may have, just symptomatic barriers that prevent them from accessing health insurance. Finding the appropriate level of care can be really challenging sometimes, even in Massachusetts where we have lots of services available. Sometimes it can be really tough to actually find somebody that will take your insurance for the type of service that you need. Getting in to a service that you need, it can be challenging. For some of our folks that may have some insurance but still have big co-pays for medications, that can be an issue. Financial constraints can also come into play when you're talking about nutrition and being able to simply buy the kind of food that you would like to be able to buy. Facilitating preventive care can be tough for some of our folks. A lot of our folks have a hard time with, mammograms, GYN exams, prostate exams, and even just, getting sort of the routine screenings that people need in terms of blood tests, blood pressure checks. For kids, I think we have lots of families that struggle with being able to just sort of stay on track with, wellness visits, childhood vaccinations, all of those kinds of things. Chronic disease management can be a big issue, especially for folks with mental illness and addiction. How do you manage a diabetic diet and you're also dealing with delusions, hallucinations, maybe you're struggling with alcohol at the same time or some other substance use, trying to quit smoking. It can be very tough to try to figure out how to manage all those different conditions. Health behavior change is challenging. It's challenging for all of us. I mean, every single one of us needs to, manage our health. We all need to exercise, eat right, try to get enough sleep. And even for those of us with lots of resources and good supports, it can be challenging. So, we can only imagine how challenging it is for the folks that we work with. Cultural and linguistic barriers can also be an issue. I think particularly when you're looking at certain kinds of foods that are associated with certain cultures that may, be challenging for folks to kind of have a better balance in terms of simple carbohydrates, fats, those kinds of things. How can you actually modify some of those foods that are very culturally appropriate but may need a different way of preparing them? Linguistic barriers absolutely have an impact when you're trying to provide wellness services in terms of, just being able to speak the language, being able to explain, how to use the gym, how to use a machine, whatever might be going on. So lots of issues in that area as well. We talked a little bit already about diet and nutrition. Physical activity, I think, can be challenging for a lot of folks. We do have a lot of folks that don't have cars, that do a lot of walking, but we also have, older folks, people with chronic mobility issues, pain issues, who aren't able to move as well and may not have access to other types of activities that are less impactful of joints and less likely to cause pain. Especially if somebody wants to swim or maybe, do some sort of modified exercise routine. I think even for our kids, it can be tough if they don't have adequate, playground time at school, if they're in a family situation where they may be in a small apartment, maybe there's not a place for them to really just go outside and run and, kind of get their energy out. Maybe, they're in a situation where it's not fully safe for them. We've been doing a lot of work with, measuring and monitoring blood pressure, even in our outpatient visits now with both adults and children. It's actually a national effort because side effects of untreated blood pressure can be so devastating in terms of stroke, heart attack, other vascular events. We're trying to do more with just, screening and making sure that people are getting treatment or modifying their psychiatric treatments so that their blood pressure may be better. Asthma, big issue with kids, adults as well. COPD, certainly a huge issue among our adult population. And, for all ages, tobacco and smoking are huge, either because the person themselves smokes or because of secondhand smoke, that somebody just may be exposed on a regular basis. For kids, there's even a lot of concern about third-hand smoke that can just be like in the carpets and the furniture, stuff that kids are going to be exposed to if they're on the floor and playing or crawling. Diabetes, much more common in our population. Folks with mental illness and addiction, comorbid diabetes is much higher than in the general population, so it's something that we're always thinking about screening for, looking for that comorbidity. I've already mentioned sleep. I think it's something that we often may overlook or not pay as much attention to as we should in terms of getting adequate amounts of sleep and decreasing barriers to adequate sleep. Kind of perhaps goes without saying that stress is a big problem. I think trying to help people to decrease stress by the social services that we provide, helping people with housing, nutrition, benefits, helping to take some of the stresses out of their life. But in addition to that, I think trying to work with people around how to simply manage stress, how to not catastrophize things in quite the same way, how to be able to, be more, mindful, using practices like yoga, stretching, even physical activity as a way to manage stress without resorting to smoking, alcohol use, drug use. Which is, one way that a lot of folks end up trying to deal with stress, and then that just creates more stress, more physical health impairments. And you can, this list could go on, but these are, I think, some of the big ones that we deal with, in particular in the populations that we serve. So what are we trying to do? Here we are, many of us, we're, mental health providers, we're substance abuse providers. We do have a primary care staff, that's working pretty diligently to also be integrating with the mental health services. So we want to broaden our services and our assessments in general to be more integrated. If I do an assessment on somebody and I know everything about their past psychiatric history, every hospitalization they've ever had, every suicide attempt, what kind of trauma they had as a kid, all of that. If I all of a sudden, I don't recognize that, they have hepatitis C, they've got diabetes, they've, been exposed to tuberculosis at a homeless shelter, and they end up having some major complications in those areas, it's absolutely going to affect their ability to be in counseling, to participate in programs, and certainly is going to affect the medications that might get prescribed. So we really need to be thinking about this in a holistic way. It also is the way that patients think about themselves, right? I mean, the individuals we serve, they don't divide themselves up into categories. And I think, not that we're going to treat everything, but to know what's going on so that we kind of make sure that, the areas that are most in need are getting addressed, that they, that people have the services that they need to address all the problems that they may have. And then to just, make a plan, and also for people to really be working to help the individuals we work with, to empower them to be doing things that are going to help their health to be better. We can give advice, we can make recommendations, we can give prognosis, we can tell people all kinds of things that are going to happen, but until that person really owns their own recovery for themselves, and I think, those of us that have worked in addiction for a long time know that to be true, but it's true in general of health and mental health as well. We're only there a small amount of time, and it's really up to that patient and family to move forward with recovery and really managing their health conditions. We just talked about this a little bit. What came first, the chicken or the egg? If you're very depressed and you're not sleeping well, you're drinking, your diabetes then gets more out of control, and if you're working, you're in school, you're volunteering, you're a parent, you're trying to care for your children, you're trying to care for, elders in your family that need assistance. how are you going to manage that if your depression is out of control? At the same time, if your diabetes is out of control, and I certainly see this all the time, it's very difficult to then, help a person to manage their depression. Adjusting their medicine for depression or even their counseling may not help all that much if, they have a blood sugar of, 300 most of the day. They're kind of, in a fog, not feeling very well. So, everything affects everything else. And, what's primary, what's secondary, often can be very hard to sort that out, and we really have to think about things in a kind of, comorbid, but also co-treatment, and what can you bring to bear that's going to help with all of these things. So just, sort of referring back to Larry again, who's had all these major issues. I think the things we've just talked about are certainly reflected in the issues that Larry is dealing with. The same thing with Nina. How are we going to try to be able to impact through having a more integrated approach? What's going on with Nina. I think the whole issue of diabetes with kids that also have a lot of behavioral issues and substance use issues is a very big challenge. I know, talking with our staff that work with kids in adolescent detox, it's been a big issue for them. And certainly in our elder population as well. So if you're working outpatient, if you're working in any service where someone is ultimately going to be, going back out into the community, doing appointments in the community, and we're trying to help them to be able to not only get their psychiatric care taken care of in the outpatient world, but their physical health care as well. This is kind of a list of questions that may be helpful as you're sort of helping individuals to prepare for appointments, to sort of strategize around how to better, make those appointments be worthwhile and helpful for them. So you want to, work with people around what their concerns are, what their questions are. It can be very helpful to write these things down. I've had many appointments with patients where if they've written some things down, they may have a question that I would never think of, or that I have no idea that is worrying them, about their medications, about their diagnosis, about, some aspect of their care or the situation in their life. So, the writing down the high points of things that they really want to be sure to ask is helpful. If people have trouble getting to appointments, which is obviously a huge issue, doing a little problem solving with them around, all right, what's going to get in your way? How are you going to manage that? Even kind of walking people through the steps that they take before going to an appointment, or if they start to get nervous about going to an appointment. If you're working in a residential program and, you may be trying to help them get there, what's your role going to be? Are you going to accompany them? Are you going to go into the meeting with them? Are you going to try to kind of pave the way? Are you going to be more of a coach? What is your role going to be? It may be helpful to enlist other supporters. I can think of situations where, in our wellness clinic here at 72 Jakes Ave, can a family member go with somebody who's got to make it to that colonoscopy appointment and get a ride home? I mean, even if their relationship may not be the greatest, is there a way to sort of pull in some other assistance that really just might help somebody get over that hurdle of getting to that, that appointment that they just always miss or they always cancel. I think helping people to sort of recognize the intimidation factor that a lot of times, and I think we've all experienced this, we go to a healthcare provider, we may not know them that well. Even if we do know them, we may feel like, oh, they're going to judge me, they're going to, I've been doing this, that, and the other thing, they're going to be mad at me. That feeling of not being able to sort of speak up or feeling ashamed about something. So, kind of walking people through those kinds of experiences, I think is helpful. I think especially if there's a service that somebody really needs from, say, a particular specialist, and they just kind of need to get over the hump of being, fearful of that, it can be helpful to really talk with people about the intimidation factor. As we all know, whenever people go for appointments, they may have to wait. And waiting can just be a tinderbox of all that anxiety, all that ambivalence just comes to the surface. I'm not waiting, I'm leaving. And so you actually got there, the appointment is in place, and you didn't manage to get through the appointment. So, if people can bring something to read, if they have games on their phone, if they, plan to kind of just get up and walk periodically. I mean, hopefully, wherever somebody's going, they're not going to have to wait too long. If somebody really has a hard time waiting, is there some way that someone could go with them, and help them, talk with them, just, make sure that they're not going to, flee once they get there. And then again, continuing to do a little bit of role playing if people really have a hard time with being able to kind of stay calm and communicate in an appointment. One of the things that you can do if your role is to perhaps be a care manager, a care coordinator, if you're a residential staff person, that, a lot of times primary care providers, our own primary care providers are still learning about all the different services we have at Community Health Link and the roles of staff. So if somebody's getting primary care outside of Community Health Link, and certainly at this point all of our pediatric patients are getting care outside of Community Health Link, what can you do that might be helpful, whatever your role might be. Can you give an update to the primary care provider, obviously with, the permission of the individual or the family in advance of the appointment? And typically it's better if it's maybe done the day before rather than day of, because once you get to day of, if people are really busy, they may not have a chance to check their messages until later in the day. Can you actually, so let's just say, you're working with a kid with childhood obesity, their blood sugar may be a little bit borderline, there's diabetes in their family, this kid is depressed, they've had some trauma in their life. Is there a way that, you as the therapist or you as maybe the family partner or, whatever your role might be, can you actually kind of help to bring in some of the goals of the physical health provider into the intervention plans that you're doing with regard to, the child doing better in school and being able to pay attention and sleeping better and eating better, that are going to help with their mood, their anxiety, their performance, all of those things. Developing a relationship with office staff, especially for our nurse care managers, our medical assistants, a lot of our residential staff, if there's somebody that, is a pretty regular attender at a particular, whether it's primary care, neurology, endocrinology, whatever it might be, getting to know that front office staff can be very helpful, especially if somebody's having a bad day, you're trying to help them make it to an appointment, the front office staff can be like your best friend. If you are able to sort of call ahead and say, hey, I'm bringing so-and-so in, they're having a little bit of a tough time right now. What should we do? Should we wait and come, are they running behind? Maybe we should wait and come a little bit later. What do you think? That you can always kind of strategize, rather than finding out, after the fact and then it takes months to, reschedule something. Is there a way to kind of be able to, with that relationship, kind of make things happen. I think it's also helpful when the front office staff may know that people's difficulty with appointments isn't just because they don't, they're not just blowing it off, but they may just really have challenges in being able to follow through. And I think when you can align with the front office staff, it will help. Maybe they can try to, maneuver the time so that it's at a certain time of day, which will make it more likely that the person will be successful. We do this a lot, but I would just, don't get discouraged about it. Giving information in terms of, getting the releases signed in advance, making sure that primary care or whoever the specialist is has has all the contact information. That can be true with psychiatric appointments too. I mean, you know, any healthcare provider, right? That it's very clear sort of how to make communication. And when somebody does go to an appointment, just making sure that they have like a full list of all their medications. We all are needing to do medication reconciliation and checking for drug side effects. So you don't want to just send the list of the meds that that particular provider is prescribing. You want to send the whole list so they know if there's something that might be interacting that isn't great. And then, you know, really trying to set up some two-way communication. I mean, often the primary care provider themselves is super busy, and it can be hard to, you know, directly have that, you know, verbal contact. But if you can, you know, if you can send in something and encourage them to even, you know, we try to just print out our little, you know, clinical summary at the end and have people take that back. We can often send that over to primary care. Trying to set up some two-way communication, and often, again, it can be through the front office staff, the nurse in the office, the medical assistant. That may be your best bet of two-way communication. So I think probably a lot of you have sort of looked at stages of change. We're going to just switch gears a little bit and talk about you know, the individual person or family, perhaps, and kind of where they're at with, you know, being ready to, you know, maybe access primary care, maybe quit smoking, maybe make some changes in nutrition, maybe trying to look at the whole thing. You know, there's sort of the spot where somebody is just really pre-contemplative, like you're just not really, I mean, you may be getting information, but you're not really contemplating making any changes. And I think we see a lot of folks that are in kind of a pre-contemplative stage, and I think part of our role as healthcare providers, whatever our role may be to sort of, you know, kind of help people sort of have the information they need, the data they need to hopefully begin to get to the next phase. Contemplation means at least, okay, I know I have a problem. All right, I went to the hospital with pneumonia. I really can't keep smoking a pack a day. I mean, I've got to do something about this. And often it's situations like that will cause somebody to become contemplative and even to start to perhaps prepare to take some action. And the action step, you know, and people can sort of go through these phases. It's not linear all the time, as we all know, right? I mean, that you may be, you know, I don't know if you can ever completely go back to pre-contemplative, but certainly you can go from contemplative to action to maintenance. But then, you know, relapse can happen, and then how do you kind of get back on the, you know, back on the path? I think helping people to understand that it's not linear and that it doesn't mean you're a failure if it's not linear, that it's normal not to be linear is helpful, and that a lot of times people, you know, and especially over a lifetime, you know, sometimes people are able to make more changes than others. So, but, you know, I think that this stages of change is helpful in just sort of thinking about where is somebody at and how can I best intervene. So we're going to talk a little bit about using motivational interviewing and solution-focused techniques. So motivation is gained. This is what we would say about the spirit of motivational interviewing in the presence of active collaboration and shared decision-making. So I think that when you're with someone, and you're kind of telling them, now you should do this, you should do that, and they're sitting there, yes, I know, yes, I know, yes, I know. That may actually be making it worse instead of better. It may be making the person feel so discouraged that they just feel like it's hopeless, I can't do this, I'm not capable, my life doesn't matter anyway, you know, whatever. So you know, that kind of imbalance of discussion is often not helpful. So what we want to try to do is to really help that person be able to talk about things that they may want to do differently, collaborate with them, and to really help people to bring up the inherent resources that they have inside themselves to make changes. And if they have a goal and they have a resource within themselves, or a resource that they know they can access, that's going to help them not only be able to, potentially reach this goal, but then to reach other goals that are related to that. I mean, that's when people really start to get motivated, to feel more hope, to feel more empowerment to make change. I mean, let's just say that somebody decided, that they would really like to be able to work part-time at the flower shop down the street. And one of the requirements of the flower shop down the street is that they have a no smoking policy, and you can't actually smoke while you're at work. But you love flowers, you love the environment there, the people are really nice, and so what can you do? And is it possible that maybe I can't quit smoking right now, but could I maybe not smoke while I'm at work? So I put on my patch, or I take my my gum or whatever it might be, and I'm gonna be there for several hours, and maybe I am gonna smoke when I leave, but I'm not gonna take any smoke breaks while I'm there. It's gonna help me to have this, so I'm decreasing my smoking, and I'm able to sort of reach this goal of working in the flower shop, just using that as an example. There could be lots of other examples like that, but helping somebody to sort of, kind of tap into, if you just sort of give a lecture about smoking, it may just sort of go nowhere. But if somebody really has a goal that might be better served by decreasing their smoking, then maybe that's going to be helpful. We are the consultants. People are experts in their own lives, and I feel like I have learned that lesson over and over and over again all these years. So, and it's very humbling, but I think it's we just need to try to be able to understand as best we can, and to help people to use their their strength and power to be able to make changes. I mean, think about a time in your own life when you made a change. What did you do to successfully make a change? Whether it was a change in a health behavior, did you ever quit smoking? Did you ever have trouble with substances? Did you ever have, treatment for a mental health condition that, was really, causing a lot of trouble in your life? What helped? What didn't help? I think sometimes if we kind of just sort of bring it back to ourselves and think about, all right, so how do I make a change? I mean, we don't want to, I'm not suggesting that we should, be saying to people, oh yeah, your situation reminds me of my life, and this is, that we don't necessarily want to do that. I mean, if we're working as a peer specialist, we may use some of those kinds of stories, or even if we're working in more of a peer kind of setting. I mean, the focus is still on what this person is dealing with, but I think if we also do think about, what has our own change process been like. When you have been able to support somebody else making a change, what did you do that actually seemed to make a difference? Sometimes I feel like, people have been able to make a change even by small things that I might have done that I had no idea would actually impact them. Somebody will come back to me and say, well, you said, 6 months ago this, which I don't even remember saying, and somebody that stuck with them somehow, and did kind of planted a seed that then, resulted in some change down the road. So, just trying to stay consistent, trying to be present with people, really listening, giving, collaborative feedback that isn't just, advice giving and, kind of talking down to somebody, but trying to keep that sort of active collaboration going and thinking about how that can be helpful. I think this idea about using open-ended questions to be able to get information is super helpful. Because I think sometimes if we ask things in a certain way, we're already sort of prejudging what's going on. So what kind of physical activity do you like to do? Or, are there places that you normally walk to get your errands done? Or do you have any stairs in your building? Or, just kind of open-ended questions like that. One of the things I do when talking about people's medication is to just say, just let me know, what are you taking? How are you taking it? Even if it, I will sometimes say, even if you think it's not exactly the way that it's supposed to be, it's better to know what you're actually doing. And then trying to give people some positive feedback about the things that they are doing. So even if things aren't going 100% the way that we would recommend, to just say, hey, you're hanging in there with this, you're trying to, do the right thing, that's great. I'm glad you've had some flexibility with this particular thing, and, let's see how that goes. So always sort of looking for that, nugget of positive activity that somebody's doing, or even something that they're thinking about, because I think all of us are more likely to go forward if there is a positive comment as opposed to a negative comment. One of the things that's very commonly used in motivational interviewing is scaling questions. And we can use scaling questions actually in lots of different ways, but you can use scaling questions in terms of, how much do you think that this is an area you want to work on, 1 to 10? How much do you think this is something that you have the ability to make a change for, 1 to 10? And how important do you think it is for your life, your health? So somebody might say that with smoking, that it's a 10 in terms of importance, it's a 10 in terms of their life, but they might say, I'm at a 1 in terms of my, my motivation or, ability to make a change. So this is just an example of using the 1 to 10 scale, and you can also use it then in follow-up questions. So if you say on a scale of 1 to 10, how much of an issue is this for you, your child, your family, your friend? And then say, why? So why is it a 10? Why is it a 1? Why is it a 5 or a 6? And then if it's of low importance, but it's something that is something pretty significant, what do you think it would take for you to go to a higher number? Sort of playing around with those scales. I think that sometimes, I know sometimes when I use scaling questions, I assume that it's super important for somebody. I find out it's not, or vice versa. More often vice versa. I think that they have sort of decided not to work on this area, and then all of a sudden I realize, they're really worried about it much more than I thought. The same way, so how much of a problem is it? How much is it a priority for you? I think one of the things that happens all the time, I know this happens with the folks that I see, is that people will say, I'm going through this, I'm going through that, I'm dealing with this, I'm dealing with that, and I just can't even face smoking right now. And I just can't. Even if I think it's a 10, it's just a 1 in terms of my priorities right now. I'm just not going to be able to do it. And I'm just using that as an example. There may be other things. I can think of somebody that I've been seeing recently where we made some big medication changes because he had gained so much weight, lost about 100 pounds, but also became very psychiatrically unstable over a period of a long time. And finally, we ended up having to go back to a combination of medication that he'd been on when he'd been more stable, but caused a lot more weight gain. And at this moment, the weight gain has taken a lower priority compared to, getting more psychiatrically stable. And so now we're just really trying to work on the lifestyle piece, if at all possible, with a better mental status. So, we have a lot of we try to do with people, and we need to prioritize, but our patients need to prioritize as well, and we try to work with that. Again, this is the piece on, how confident are you that you can make a change? This one I think is really good about what would it take to help you feel more confident. How could you go from a 4 to a 6? What would it take? Is there something that we could do? Is there something that that you might want to explore? Whatever it might be. Developing a change plan can be challenging. And as our cartoon says here, sometimes it's good to change your walking routine. Try walking around the block instead of wandering around the kitchen. I mean, probably a good idea. Depending on where you live, though. Maybe it is, maybe it isn't. So when somebody is really at the point of wanting to take action, hopefully you will have some mutually agreed upon goals. It's their goals. You're going to know about the goals. You're going to talk about what initial progress might look like and how are you going to track it. I actually find that I do this a lot with some of my folks with developmental disabilities who don't have a lot of verbal reporting skills, that we decide, okay, what are the measures, what are the behaviors that we're going to notice if things are getting better or if things are getting worse? What are we going to track? So for somebody, for example, I've had some people that will say, well, you know what, I'm just going to start cutting down by 1 cigarette every few days. So, I'm going to, pack is 20 cigarettes, so by, the end of 2 months, I want to be down to 10 cigarettes, and I'm going to go down by 1 cigarette a day for, I'm just using that as an example, but sometimes people will make plans like that. People may make plans, well, we'll talk about that more, sort of what I will do, what I won't do. So for kind of an action plan and what are you actually going to do? So if something is working for you, if somebody actually, they already, walk a mile or 2 a day, they don't have a car, they're already doing that, let's just reinforce that. That's great. If you're walking a mile or 2 a day and you're working on obesity, maybe do you pick up the pace a little bit? Do you try to, maybe go a little bit longer route? There's good information to say that if somebody walks an hour a day, they can probably, lose 15 or 16 pounds in a year, whatever. So building on, I'm just using that as an example, but building on something that somebody already does. And to how to, sort of maybe do more of that if that's working for them. And if something really isn't working, well, is there something else that they could try? And even if it's just really small things, like I always tell people, I sort of talk with people about soda, because soda is such a problem in terms of weight gain, diabetes. There's just, more and more data about, sort of the negative health effects of soda. So, can somebody just cut down by a certain amount? Or I have had a fair number of people who've been able to sort of figure out what are they going to drink instead of soda. It's turning out diet soda isn't as great either, but if they can make that step and then maybe take the step to go to, seltzer water or water, put a little lemon in it or something like that, whatever it might be. Again, I'm just using that as an example. And I think, this whole idea that the solution is not necessarily related to the problem, this may sound sort of like, what does that mean? That somebody may do something that's a positive step in their life, and then it may actually help them do better in other areas that they're not necessarily targeting. I just use the example of the work in the flower shop. So if you look at that from a different angle, and you just left out the smoking piece altogether, if you just focused on the fact that this person has decided they want to work in the flower shop, or they want to volunteer in the flower shop, or their friend is working at the flower shop and they want to go help them in the flower shop, and that's actually their goal. And then, as it turns out, they can't smoke there, so, I just won't smoke when I go there. And they weren't even really thinking about the smoking, they were just thinking about the flower shop. So I do think that, one of the wellness activities that people are doing in our Leominster clinic, there's been and actually in Worcester too, there's been a group of people that have decided to sort of take up knitting, take up crocheting, and you're thinking, all right, well, that's not physically active and it's not a change in diet, but what happens when you do that? All right, so you get together with people, you decrease social isolation, you're not smoking, you're not snacking, you may actually end up having some weight loss, some better nutrition because you were, knitting with a group of friends, so again, I'm just using that as an example. And one thing to also remind people is that, change is going to happen all the time, no matter what we do. Change for the better, change for the worse, change, just it's the way life is. And that, people can make change, that things don't always stay the same. People are not always stuck. All it takes is one step forward. I am really a big proponent of this, that doing almost anything is better than nothing. And one of the reasons that I think that this is true is because I think many of us have heard the statement that, whatever you think about or however you sort of train your thoughts towards, that's where your brain starts to go. So even just little things like, okay, I can decide not to drink Coke the first thing I get up in the morning, or I can decide that I'm going to go for a walk for 15 minutes, or I can decide, whatever it might be, that I'm going to, and that I can make the decision and that I can actually do it. And just doing something little is great. And for almost all kind of bigger changes, it's a whole bunch of little changes that actually go into effect. If somebody's trying to lose weight or quit smoking or increase their physical activity, there's a whole lot of little things, that this might have a 10% impact, this might have a 10% impact. And helping people to just kind of give themselves credit for the things that they are doing. There's actually a number of, books these days that are out there, and I think a fair amount of research on this, but that, if you've been able to sort of do something fairly regularly for about 3 months, it does start to become a habit. That can be both true of good habits and of bad habits, but or habits that aren't so healthy or habits that are more healthy. Again, I think just continuing to reinforce with people that change is possible. How do you create a plan? One way I want to improve my health, maybe what they're going to say is, I am going to go to Everyday Miracles and have lunch there instead of, sitting in my apartment, craving cocaine or heroin and, being by myself and relapsing. I mean, I'm just using that as an example. And so when will I start? What will I do? Well, all right, tomorrow I'm going to go, even if I only go for, a few minutes, I'm going to walk in the door, I'm going to go inside. How often will I do it? Maybe for right now, I'm just going to say, I'm going to do it tomorrow. That's all. I'm just going to do it tomorrow. I'm going to reassess. Or maybe I'm going to say, you know what? I have to go downtown to do X, Y, and Z that's near there pretty much every Monday and Wednesday. So I'm at least going to go on Monday and Wednesday when I'm already down there for something else. What might get in the way? How can I address it? Well, what might get in the way is if I just say, I don't want to go. I might run into somebody that I'm going to get mad at. That person I had a fight with at a meeting a couple weeks ago, I bet they go there. I don't want to run into them. All right, so what are you going to do? So what might get in the way? Or what if you do run into them? You might run into them anywhere. You're going to give that person that kind of power over you. Anyway, I'm just using that as an example. And if Plan B doesn't work and you don't make it to Everyday Miracles, or it turns out that it's not such a good idea, all right, what's Plan B? All right, maybe. All right, there's an AA meeting that I know that's probably only about a few blocks from my house. It's not my favorite meeting, but you know what? I haven't been there a long time. I'm going to try. That'll be Plan B. If I don't make it to Everyday Miracles, I'm going to do this other thing. And then Again, if you're doing outpatient work or you're, in residential or whatever, all right, when are we going to check in about this again? And you can make a plan that you're going to check in at your next visit with that person. You can also make a plan that, hey, leave me a message, write it down in your journal, or, if you have a little book, and then let's review that the next time you come in. Even if it didn't work, then let's just talk about what happened. If it did work, great, let's talk about what happened. But trying to stay, when you're working with somebody, it's hard to be neutral, it's hard to stay non-judgmental, because we're obviously rooting for the health behavior change that we would like to see, but to also just, try to really feel like, okay, I'm going to help you figure out how you're going to do this. And this is not about pleasing me or upsetting me, this is about you. So how do you define progress? How do you define how these goals are working? And this is actually now looking a little bit more at solution-focused therapy. So if you think about it, and you think about people coming and getting our services, and you think about actually how hard it is to actually make even that first step of calling and asking for help and then showing up in whatever way somebody got here. If they got here by ambulance from the ER, or they got here because their parents dragged them in, or they got here because they wanted to, or they got referred by somebody else that made them come, whatever it is, just getting here is an accomplishment. So for people that have actually called for help, or someone else has called for help, one of the things that solution-focused therapy uses is, even just between the time that you made the appointment and the time that you came, have you noticed anything that might be a little bit better? And, if our treatment here is going to be helpful, what is it that you're going to notice is different? Like, what are you hoping for will be different from our meetings together? The miracle question is an interesting question, and for any of you that have worked with, Dr. Ann Lutz, who is a national and even international expert in solution-focused therapy, the question about, if you woke up tomorrow morning and all the problems were solved, how would you know? I mean, what would life look like? And no one told you that this was going to happen. What would things look like? How would your life be at that time? And then if there's some way to help people see, okay, what little part of this miracle might already be happening, and is there a way to sort of grow that piece? And the other thing that solution-focused therapy is really good with is, given all the troubles people have, how do you cope now? I mean, how do you make it through the day? And a lot of times people will be so negative about themselves, oh, I'm terrible, I drink too much, whatever, but I think helping people to even see, small kindnesses that they give to other people, or ways in which they interact with their neighbors, or they try to keep their apartment reasonably clean, or they try to help their mother, or whatever it might be. I mean, what are the little things that people sometimes really do that helps them to just do better? And one other question can be helpful. So when you are no longer feeling like using heroin, cocaine, alcohol, marijuana, tobacco, excess sugar, scratch tickets, whatever it might be, how would you feel instead? So whatever that, when you're no longer feeling depressed, when you're no longer feeling, this hopeless, what would you feel instead? So, you can sort of fill in the blank. There's ways to do things that are positive as a way of making change. So I am going to add a serving of vegetables. I'm going to take a walk. I'm going to pack a healthy snack. I'm going to do 5 minutes of meditation before I go to bed, or 5 minutes in the morning when I get up. I always skip breakfast. I run out the door, or I just get up and I feel lousy and I just don't eat, and then I, eat way too much later. I'm going to eat a healthy breakfast. So, positive changes. And this again is a way in which, you add something and then it may help something else to decrease. But the focus is on the positive, not on the negative. And then you might replace a negative. And we talked about this a little bit earlier, drinking water instead of soda or so much coffee, taking the stairs instead of the elevator. I'm going to walk to school or to wherever I go instead of, driving or getting on the bus. And if I do get on the bus, maybe I'm going to get off, I'm going to plan to get off a few stops earlier than I normally would. Instead of going to the vending machine and getting cookies in the afternoon, I'm going to bring, some vegetables or something that I'm going to keep with me. I'm going to go outside and just take a walk, either with myself or a friend, instead of going out for a smoke. That you can take a break and go outside without smoking. It's okay. And then, there's another way to look at some of these things, but sometimes you may not want to substitute, maybe not adding something, but there's just something, I just don't want to do that anymore. All right, so I'm just not going to go to the vending machine. There's nothing healthy in there. I'm just not going to go to the vending machine. This example of popcorn at the movies, if you get, popcorn at the movies and it's drenched in salt and lots of butter, I'm just not going to do that. Smoke only 1 cigarette instead of 2 cigarettes. And I think some of these, stop drinking soda, stop smoking, stop going to fast food places. It can be hard. It can be hard to just say I'm going to quit if there isn't something else to replace it. There's almost always got to be something else to replace it, although that may not be the thing that the person is focusing on right at that moment. I will say something about quitting eating after 7 p.m. I've actually had a few patients who I learned this from them, that they just sort of set a certain time. It doesn't have to be 7 p.m. It could be, whatever time. But they just didn't eat anything after 7 p.m. until the next morning. And I had one woman that lost 50 pounds, and that's all she did. She didn't really change anything else. But of course did a lot of, kind of unhealthy snacking late at night. And I'm trying to recall what she did instead. I don't know that she really talked about that so much. She was very proud of the fact that she stopped eating after 7 o'clock. Sometimes this is helpful if people can sort of think, okay, and I do this with people a lot with the cost of cigarettes. It's a little harder if people are rolling their own in terms of the cost, but if you look at the dramatically high price of cigarettes and you just sort of added up how much money you would have if you weren't buying cigarettes, could you get some new clothes? Could you, get some music that you like? Could you, even if you can't go on a vacation, could you, could you go to the movies? Could you maybe go to a restaurant? Could you, go to the grocery store and get some food that you really like? Stuff that you really enjoy. That might be a little pricier. If there's ways that people can sort of think about that, or if somebody has really got, like, let's say somebody's got a goal of, losing 25 pounds and they really diligently do it, is there a way to set up some sort of, okay, when I, at the point that I get to that goal, I'm going to reward myself with, or the rest of the world, support system says, hey, we're going to have a celebration because this is a huge accomplishment. Also with motivation, with solution-focused therapy, rather than saying, so, how are you doing today, or what kind of problems are you having that you want to talk about today, you might say, so tell me about what's just a little bit better than last time. And why not start with that instead of with everything that's wrong? What's a little bit better than last time? And then, using those scaling questions, on a scale of 1 to 10, is it, this time it was a 2 last time, it's a 3 this time, or, whatever it might be. Gently checking homework assignments. I think that gently means, that, what do you mean you didn't do this? We said we were going to do this, you didn't do it, what's that? You're not going to come across like that, but just talking with somebody about, last time we said, that you were gonna, this is what you said your goal was, just checking in with you, how did that go? Did you, bring your journal, can we take a look at that? And then ask about what's different since last time. Have you learned something? I mean, even if okay, I said I was going to do this and I didn't do any of it, but what did you learn? So what got in the way? Maybe that's where we need to start, is sort of looking at what is getting in the way, and then start with making some changes in that area. So whatever it is, there's always a way to learn. So when the doctor said I had diabetes, I couldn't believe it. I want to feel better, but taking medication every day sounds like a hassle. Can't I just cut out the sweets? I lost 40 pounds when I joined the Army years ago, and I'm not letting this take over my life now. I think that when somebody, kind of comes in and they often tell you, in the first minutes you're sitting down with somebody, or you're their residential counselor, or you're working with a family, all of a sudden you kind of get this litany of stuff that kind of comes out, right at the beginning. Try to reflect back to people what you have heard them say. Okay, so what I hear you saying is you want to feel better. You're considering whether the medication could be helpful for you. You're also saying this has really been hard for you, but that you're not going to give up without a fight. So if there's a way to somewhat reframe, but not reframe too much. I mean, but to kind of say back to the person the strength that you're hearing in whatever they're presenting to you can be really helpful. I mean, sometimes if it's nothing more than, I can hear that you're really upset about this, and you know what, you would not be really upset about this if you didn't care. I mean, you wouldn't even tell me about it if you didn't care. So the fact that you even told me about it means that you're thinking about it. And then these are just some more potential questions that you can ask in a solution-focused therapy kind of way. What would be good about this? What else have you been thinking about? How might you make the best of, there are lots of situations that our folks are in that they can't change, housing, families, lots of circumstances that are kind of beyond their control. Is there a way that you can make the best of this? What keeps it going now? I mean, how do you make the best of it now? What might you do a little bit differently that might be helpful? Where does this lead you? What's your next step? What do you think should be your next step? I think it also helps to sort of take it out of that we are the facilitator of their change, not that we're going to come up with some magic answer that's going to work or some magic pill that's going to work, because unfortunately we don't have any of those. So we're thinking holistically, mind, body, spirit, as we've been talking about. So we're going to switch gears a little bit into some examples of wellness strategies. And let's talk a little bit about nutrition. So one thing that can be helpful, and again, if you're a residential counselor, if you're a nurse manager, if you are a family partner, you're a peer specialist, you might have the opportunity to be shopping with people. This could be at a food bank, it could be at a grocery store. When I have worked on these sort of community treatment teams in the past, we called it therapeutic grocery shopping, where you just kind of went in and looked at what was there and tried to make, if there's a choice between brown rice and white rice, if there's a choice between whole grain and white flour bread, or whatever the case may be. In the grocery store, typically most grocery stores are set up if you shop the perimeter, that you're going to be able to get more of the fresh foods and the things that are less highly processed if you sort of go around the edge basically of the grocery store. And how to do that with the limited budgets that people have absolutely can be very challenging. But I think sort of, working with folks around what kind of foods are important to them, Are there ways to make these foods that are less expensive? You know, I think a lot of our folks, especially our single adults, a lot of times don't do a whole lot of cooking. They don't, you know, they may not be in a family situation. It may be hard for them to think about cooking, but maybe brainstorming with them a little bit about that. I know that in many of our residential programs, there are joint cooking projects with healthy food. I know our wellness staff in Leominster has been doing joint cooking projects. And even, you know, helping people to sort of learn simple things like, you know, if you have, you know, a can of beans that has salt in it, if you simply like rinse them off before you know, put them in your rice, you're going to like dramatically lower the salt content. I mean, sometimes people just don't know, you know, they don't know that, or they maybe don't know about, you know, getting kind of the low sodium variety. And there's more and more of those, even of like the store brands. I've been noticing that in a lot of the grocery stores. You know, are there some local nutrition extension services or other kinds of services? You know, in Worcester we have the Regional Environmental Council that's very active in local gardening. It's actually an opportunity for kids especially to get involved. You know, we've had an organization called Cooking Matters in Leominster that's been very helpful with some of our clients. So some of the grocery stores will actually do tours. I've noticed some of the grocery stores will say, especially if you're a diabetic, that there's somebody from the store that will take you around the store and kind of show you. I still try to encourage people with diabetes not to buy too much stuff that's, you know, just got, you know, fake sugar in it. I mean, it's still better to go with more natural, unprocessed foods, but still, it can just be really helpful for people to have that perspective from the grocery store. One of the things we can do is, and I know this is still challenging for us in our meetings and stuff, is to, you know, try to have healthier foods. You know, do we have some salad? Do we have some fruit? Is everything just, you know, a sandwich, chips, and a cookie? You know, when we have a lunch or we have an event of some kind. I mean, sandwich, chips, and cookies are easy, but they're not necessarily, you know, what we would aspire to have for our own nutrition. One of the things that some people do is to have culture days where you might introduce new foods. I'll just use rice and beans as an example. I mean, rice and beans is sort of, you know, many cultures have versions of rice and beans, and it's, you know, it's a whole protein. People don't know sometimes that vegetables, you know, if you put the right kind of things together, you've got a whole protein. I always tell people, you know, look at cows, look at horses, look at elephants. They don't eat any meat whatsoever, and they're huge, muscular, healthy animals, and you know, trying to help people sort of think a little bit differently about the kind of food that they eat. This is an example of some strategies around sleep. I think I spend probably 25% of my psychiatric visits with patients talking about sleep. It is such a big issue for people. You know, medications can make it harder to sleep or make you sleep too much. Caffeine can make it hard to sleep, or then you use too much caffeine to stay awake, and then that causes anxiety and jitteriness. Waking up in the middle of the night and smoking, that is one of my main, I probably get very prescriptive about that. I will have to say I probably lose my collaborative way of talking to somebody, and I say, just don't smoke in the middle of the night, please, because it's just waking you up, you know. And somebody that wakes up in the middle of the night, has a cup of coffee and a cigarette, and then tries to go back to bed, well, all bets are off. I mean, so, but again, trying to do this, and myself included, trying to do this in an exploratory, helpful, non-judgmental way. It's hard. I mean, as a provider, it's hard to do. So I think the more that we can, you know, so if somebody's goal is to sleep better, just kind of helping to sort of lay out the facts. You know, these are the things that are going to help. I think a lot of times we do need to look at substitutions. So if somebody has been getting up in the middle of the night and smoking, what are you going to do at that time when you wake up? You know, are you going to try to do some kind of meditation? Are you going to maybe just get up and go to the bathroom and have a drink of water and then go back to bed? You know, if you are awake, you know, can you just leave the lights off so that you don't, you know, stimulate your brain? You know, kind of thinking about all of those kinds of things. Exercise can really promote good sleep. Some would say that it's better if the exercise is done in the morning or the afternoon. There's been some recent research that sort of says, almost any time of day, even if it's fairly close to the time you go to bed, doesn't necessarily make such a big deal. And if that's a good time for people to exercise, we don't want to discourage them. Sometimes doing some gentle exercise right before bed is really helpful. So some yoga stretching, putting your feet up against the wall. Sometimes that can just really just help to kind of settle things down a little bit. A lot of food right before sleep is often disruptive, especially if people have any, esophageal reflux, or, sometimes it just is stimulating. I mean, people will just get kind of energized if they eat right before they go to bed. For other people, they eat a lot of sugar because it makes them tired, and that helps them to go to sleep. So again, trying to help somebody figure out some other strategy. Big problem is electronics. All of us looking at screens, as we are doing right this very second, with bright light right before we try to go to bed at night. It's sort of like telling your brain, okay, it's morning, it's awake time, it's time to think about all these, very stimulating and sometimes disturbing things, and okay, go to sleep. I mean, excuse me, really problematic, and especially with a lot of the young people that I work with who are really into video games, it can just be really challenging. So sometimes people will sort of, try to figure out, okay, there's a certain time at which I'm going to turn off my electronics. People are getting the background, like there's a way that you can change the color of your screen in the evening after a certain time, so at least it's not projecting bright light into your eyes. The other thing I try to do is to encourage people to get up in the morning and go outside during morning hours, even in cold weather, and just get some natural sunlight into your eyes, because that actually sets your clock for being awake during the day, and then to have better sleep at night. Staying in bed way too long is not helpful. I have a lot of folks that struggle with this. They don't sleep well, so then they try to go to bed earlier, then they're upset that they can't go to sleep, then they sleep a little bit, then they get up, then they go back, and by the time it's all done, they've been in bed for 13 or 14 hours, and they've maybe slept 6 of those hours, and then they fall asleep at some other time. So really trying to establish, kind of trying to be in bed for the hours that you're intending to sleep. Not a great idea to be watching TV in bed. I know a lot of people do it. A lot of people have TVs in their bedroom. But again, that bright light, that stimulation, it's hitting your eyeballs. The sound itself, and even if you fall asleep in front of the TV, there's some research that shows that light that's still filtering through your, it's not totally dark unless you're blind, obviously, but if you're a seeing person, you're still going to get light that's going to filter through, and that still can cause some disruptions in your sleep-wake cycle. So sleep is huge. There's actually a very good resource now online called Cognitive Behavioral Therapy for Insomnia, cbtforinsomnia.com. Maybe we can add it to the resources at the end of this presentation. It's by a behavioral psychologist who's affiliated with UMass. I think it costs $40, somewhere between 30 and $40. Way better than lots of other, much more costly in the end strategies. So I would encourage you to check that out. Stress management. So this is true for everyone watching this video right now and your clients. We all have stress. We all have a lot of stress. We all work at Community Health Link, so by definition, our jobs are stressful. We welcome that stress, however, because we really want to do this kind of work. We want to help people that need the most help. And so how do we manage that? So first of all, we have to think about how do we manage our own stress. Because it's very difficult to sit with the stress of others and to help others manage their stress if we're not managing our stress, because then we get too easily triggered, myself included. Happened yesterday afternoon when a patient came in unexpectedly and it was all kinds of problems, and didn't handle it as best as I could have. So this affects all of us. So thinking about, do we do any sort of, mindfulness, any sort of meditation, yoga, exercise, reading, walking, nature, talking to our family, whatever kinds of activities help us to just be happy, to sort of feel relaxed, to kind of take our mind out of work. Very, very important. I think, for a lot of us, we work a lot, we get very caught up in our work, maybe our family life may not be as calm and restful as we would like it to be. And so, how do we manage that? For many people, their religious beliefs or spiritual beliefs, being part of a community in that way is very helpful. So first and foremost with stress management, first think about yourself. And again, in a kind, compassionate, non-judgmental way. This is not to have a big to-do list, oh, now I'm doing this wrong too, but just to sort of think about, what can I do that helps to manage my stress? There's a little video here that you're not going to see right at this moment, but I would encourage you to take a look at it. It's a little corny maybe, but it's about a woman who goes into a health center and is able to get her physical health needs, her mental health needs, her substance abuse needs, her needs for help with her psychosocial stressors, kind of a one-stop shopping sort of place. And I would like to think that Community Health Inc. is striving to be that kind of place. You all that are watching this video are the bedrock of making this happen, and the way that we treat our clients and helping them to really lead the best lives that they can. With that, I will end this presentation. You all will probably have some forms that may be online that you'll be able to get about some concrete steps that you can do in your own program. And I would just encourage you to, even if you're watching this video all by yourself, just think about one thing, like we just talked about, just one thing, one little thing that you might want to do just a little bit differently, or that you might want to change. A lot of you have idea boards now. I would encourage you to be thinking about the wellness stuff and the wellness integration when you're looking at your idea boards. Maybe there's a little thing you could do on your unit, or in your clinic, or when you're doing your outreach, or if somebody always wants to go to McDonald's, maybe we'll go to Subway and not have the fried chicken sandwich, or some little things. But anyway, just some ideas. So thank you for all the work that you do, and we're all set.